Okay, so before we land this plane, I'd first like you all to join me in thanking my colleagues at the University of Rochester, the John A. Hartford Foundation, all the speakers here today, the supporters, and most importantly, all of you joining us here in Boston and online. It really was a remarkable day, so please join me. So the things that we've heard today, the discussion, the debate, the dialogue, the dedication, and the passion, give us hope. I think a great deal of hope for a better tomorrow for seniors everywhere. But hope is not a strategy, and really it never has been. We've been here before, yet we continue to see promising innovation, new models, truly disruptive change be unnecessarily denied, delayed, and deferred due to policy, practice, and even societal barriers. It's not lost on anyone, I'm sure, in this room, that it is incredibly difficult to change and fundamentally alter and penetrate a bloated, expensive, and highly entrenched system that so often rewards volume over value, in many cases, secrecy over transparency, and unfortunately, profits over patients. And as we think about the innovation that we've discussed today and that all of us are so passionate about, it really doesn't realize its true potential if we don't address these barriers and simultaneously address the skyrocketing cost of healthcare in America. Failing there, we miss an opportunity. And it's not just an economic opportunity, it's a human opportunity. I have hope that this time may be very different for three reasons. We've talked extensively, and as a group, we often talk extensively about numbers. And there is strength in numbers. Number two, value-based models and value-based payment is getting traction. And number three, which I think is fundamental and perhaps the most encouraging and the most important, is that evidence and data around senior-specific models of care, when deployed at scale, and we're now seeing these models and we're discussing them today being deployed at scale, that those models can improve outcomes, can improve quality, can improve person satisfaction, and achieve all of those things at a lower cost. So I think for those reasons, there are reasons for us to be optimistic. But we need to engage. We need to engage more aggressively than we ever have before. And perhaps there's no better place to talk of a revolution, and Shelley Lyford pointed out this morning, one is certainly needed. We need to transform our system to be more efficient, more effective, more affordable, more holistic, and ultimately more accessible and accepting of the innovations that we're advancing. Together, as payers, providers, patients, but most importantly, as voters, we need to make our voices heard. We need to advance practices and policies that really do make and enable successful aging a reality everywhere. As we talked about on the panel, the time is not in front of us. The time and the opportunity is right now. It's today. So thanks for joining us today, and I'd like to welcome Avi to offer some closing remarks as well. Thank you.
I want to provide some perspective and a quick overview of the fast-forward discussions we have had all day today. I think sometimes it's hard to realize how much territory we have covered in a fairly short amount of time. This conference is a culmination of almost 11 months of very intense preparation, getting the speakers, putting the content, putting the panels together, developing the question, logistics, etc. But all of us, Shelley, Ray, myself, we believe, Tim just mentioned it, that this is a topic that we rather address earlier than later. Not only is the cost for out-of-pocket dollars, but also human life are involved in here, which is very important. So I would like to give you a quick overview, and I start with the perspective. I want to make sure my PowerPoints are loaded. So, okay, if they are there, okay. So, how do I move the slides? This? Okay, it goes backward. One second. Are they ready to move? One second. There's only, which one? This one? No? Which one? Which one is forward? This one. Okay. Thank you. So I want to start with some critical perspective. Because we as professors, our job is not to say yes, but to say, well, but there's something else. First, the social construct of healthcare, as you heard several times today, is a big part of the clinical outcomes. Okay? There was a mention earlier this afternoon that being lonely is equivalent to smoking half a cigarette, half a pack of cigarettes, 10 cigarettes or more a day. It's very bad for your health. Okay? The problem is this: who will take care of the loneliness? We cannot ask our physicians to become cruise directors, get short pants, a t-shirt, and run around and organize the elderly. Won't happen. So this is a tough time. The other thing that hardly got any mention today is what we call public health or preventive medicine. If you want to age successfully at age 70, 80, or 90, you can't start at 65. You have to start at 30 and 40. Reduce blood pressure, reduce hyperlipidemia, change your habits, protect your liver, cut on alcohol, start exercising. Who's paying for it? Where's the reimbursement? Where's the business model? Nobody talked about it today, but remember, the individual who will be the next generation following the baby boomer 5, 10, 15 years from now are the ones who are enjoying the good life, eating the steaks, the cheese, not exercising, thinking, well, for every ill there is a pill, just pay the bill, okay? It doesn't work this way, even with CVS drugs, okay? Some things we cannot deal with. So what we need to understand is that the model of care is a lot more than reimbursement and risk sharing. There should be some systematic long-term view, which the politicians, unfortunately, on both sides of the aisle, in my humble opinion, fail to see. Because it's not only on Medicaid and Medicare reimbursement. We pay with our life, we pay with our out-of-pocket dollars. We started a day with Professor Dorsey talking about telemedicine with phenomenal success we have had in the University of Rochester under his leadership, taking care of patients both abroad as well as many of them in New York State who deal with Parkinson's disease, and the clinical results in many cases are equal or superior to what gets on with the face-to-face visit. Shelley talked about the next American revolution. We have to take things to our hand and make sure things work better. Clearly, the American healthcare system is not set to deal with this tsunami of elderly coming over, because bear in mind, most of the cost is for individuals 60 years and older, okay? Senior needs to get something which they like. Their objective is not just to live forever. It doesn't happen anyway. So how do we get a priority? What do they want? What kind of technologies we can give them, which is on high tech, but yet high touch? And how can we make it affordable, accessible, and friendly, non-threatening? Alice Bonner gave a superb presentation. Primarily, the main thing of presentation was how do we make the state of Massachusetts, the Commonwealth of Massachusetts, elderly friendly. Why is it important? Because a lot of medical services around here, yet it's a fairly expensive place to live, to get help, and so on. Bear in mind, elderly care is very much labor intensive. So how do we substitute labor for capital is a question we've all been asking, okay? Not necessarily physician labor, part of it, but human support for driving, for bathing, for cooking, etc. How do we cut on this high labor cost and still maintain quality of life for the individual? Dr. Kessel provided some very interesting insight, what we call the new normal for the aging. What happens once they cross the 75 years old boundary. Once they cross the 85 years old, as people get more fragile, more tuned to diseases and so on, okay? How do we keep the individuals working longer? How do we change the employer expectation for what gets covered, for what to expect from those individuals so they pay for themselves, but also find something meaningful so get up well in the morning? With a panel of 4 experts run by David Klein, and some of the issues was, first, what is the issue with aging? What does aging really mean? Why do we worry about it, okay? What should be covered in the future? What coverage we should add in the future that we do not have now? Will there be enough money to provide the coverage that we think the elderly deserves in the US? How we cut the cost of long-term care? Some of you may not know it, but there are several insurance companies, GE is one of them, GE Life and others, who got out of the long-term care insurance. They figure out people living longer than expected, it's costlier than expected, so we don't get new subscribers. So will the government do something like Social Security and provide long-term care? Otherwise, you sign in at age 35, at age 60, they say, you know what, we're shutting down the program. We give you some money back, go find somebody else, okay? So long-term care, it's very nice to say, well, you take a bet against yourself, you hope you don't live long so you don't have to do it, or will the money be suffice? Most insurance companies don't find long-term care an economic proposition anymore. So this is an open gap, a lot of political debate in there. I'll skip some of the comments from this discussion just to stay on time. We then had the visioning session which provided some perspective of our detailed discussion yesterday, looking at what kind of self-funded businesses, Call9 is just one example that you heard about this afternoon as well, we can bring in providing technology, high-tech and high-touch, to cut costs, cut rehospitalization, and so on. And the key issue is this: there are more opportunities, but also more challenges. One of the issues which makes us optimistic is nobody owns the market. There's a lot of room for experimentation. Individuals are willing to pay for good quality of life. And baby boomers start realizing seniors are us. It's not they, it's not my grandparents, it's us. It's the individual. If you look at the 2 individuals who ran for the president position, was it 2 years ago, almost a year and a half ago, both of them crossed the 71 or 72 years old, okay? So these are the individuals who run the country, okay? So we get a lot more active individuals than ever in the past, and they expect bigger space, bigger legroom around them, okay? We talked about that over the last few years, we see a lot more investment in the so-called senior space. It's a multi-billion-dollar space, yet there's a lot of room to improve and what's been done. They talk about the 3 Ps, I will call it the 4 Ps. The patient, the provider, the pharma, and the population at large, okay? Because the patient is affecting their externality, the caregivers, they put cost on others and so on. So we need to make sure it's not only the individual taken care of, but the family or the community at large. Now, clearly also not only coming with new technology is important, but how do we change the workflow of the physician, of the pharmacist, of the care coordinators, et cetera, et cetera. As medicine keeps progressing while we speak, we get more cures for more diseases, but we also get a lot more adverse effects, the like of which we haven't seen in the past. If you talk with the pharmacist, they'll tell you, nobody ever studied what happens when I get somebody 70 years old with 5 drugs and we add the 6 medication onto these patients. Why? Because clinical trials are not done that way. We don't do a lot of clinical trial on senior citizens, and we don't do what we call polypharmacy. We do 1 drug at a time, maybe 2 at a time. We call it A/B testing. But if you look at your average patient who is under medication, they get 4 or 5 medications, you add the 6th or the 7th, God knows what will happen, okay? So there's a major role for pharmacists in there, but there's not something we have engineered it so far. Let me just skip again here. VNA presented the whole Connected Health Institute, its innovative concept, and the whole idea there is we want to try and leverage on technology to provide better care with better ventures. Then we looked at value-based care with our afternoon panel, and the question there was, how do we use data? It's not only billing data or discharge data, but also patient data, demographic data, home sensor data, lab data, etc. How we migrate all these data elements together to get what we call in the business world predictive analytics, to analyze the state of the patient now and which way the trajectory is moving so we can take in early action there. Following the fireside chat, we basically look at ways to reform the marketplace, and several good ideas came into place. You had basically the different innovations that come around. The idea is I can reduce the current modus operandi of care delivery. I can find different channels to deliver care by substituting gaps with individual on site or with technology on site or combination. Initial results seems extremely positive, and I'm sure we'll see a lot more of it coming into the future. Now, you heard about Wallaby, Call 9s is some of those. American Well has been in the business for several years. They've presented in a conference a year or two ago, and we see the whole idea of telemedicine work makes sense for one simple reason. It is easier to move data than to move patients. That's why we don't go to the bank anymore. We do all our banking online. You see a lot of it coming with medicine as well. Now, we looked at the last presentation by Tim Brennan, kind of revolutionizing healthcare. CVS is coming in and saying, we got an asset which the hospital doesn't have. What is it? Free parking. How many hospitals you know with free parking? None. CVS, you still don't pay for parking. For me, it's a big asset. If I need to get a flu shot, I go to CVS, I'm in and out in 10 minutes. If I go to my primary care physician, it's an hour ordeal and I have to make appointment 2 weeks in advance, okay? So they have tremendous advantage on many dimensions, and you can keep looking at this from different perspectives. But clearly, they have a proposition which says, we are somewhere between the hospital, which is acute care, and the primary care physician, which is hard to see. Many of you, when you call for the primary care physician, who sees you? A nurse practitioner or a physician assistant. You don't even see your own primary care physician, even though it's on the book, and that's what the billing says. CVS says we are open 24/7, we have free parking, you are within few minutes drive, and other pharmacy chain, I'm sure, will follow suit. So there'll be demand there, and the economic model will catch up. So just kind of to wrap up our discussion, we feel that there's a lot more to be done in the future, and we want to hear from you. So what we are doing for the next 90 minutes, we got you a sunset jazz band playing for you. We'll have some great food, and we would like you to stay around, look at the exhibits, chat with each other, give your comments to Tim, Ray, myself. We would like to hear what you'd like to hear about next year. And thank you all for your participation, for all the speakers. Big hand, and let's do it.